Good afternoon. I would like to welcome warmly all who decided to join us for this seminar. Today at the Sano seminar, we have as a speaker Monika Pytlarz. Monika is PhD at Sano, and before joining PhD, Monika studied at the Jagiellonian University in Krakow, and she obtained a bachelor degree in electrocardiology from this part of Jagiellonian University, which is called Collegium Medicum. And then she obtained Master of Science in Bioinformatics, also from Jagiellonian University. But, well, besides of this, Monika has a clinical experience with being a part of a hospital diagnostic imaging department. In research at Sano, Monika is working on usage of different artificial intelligence methods, models, and trying to combine them in such a way that it is useful for clinical practice, very close to clinical practice. Well, Monika has a number of very interesting collaborations in Poland and in the States, and I hope that during the talk today she will also mention about this. And well, she also participated in a number of well-recognized conferences in her area, and she obtained quite interesting awards. You can find some information on these awards on her website at Sano. So, well, that's all for introduction. Probably it would be better it would be good to give more information, but because of the time, well, Monika, screen is yours.
Thank you so much for the kind introduction. Good afternoon, everyone. So as Marianne mentioned, I studied for bachelor's to be specialized in radiography, and I look back to this expertise while doing PhD. And today I would like to share what I learned during my doctoral internship at Children's Hospital of Philadelphia that I completed at the beginning of this year. So I was hosted by Dr. Mariam Aboyan, who is a head of Imagine Quant Research Group at Children's Hospital of Philadelphia. She's an assistant professor there and attending neuroradiologist. I learned that our scientific interests align very well, and that we are focused on not only doing research, but also offering to the patients better care and better treatment planning. And I put here briefly the lab vision of Imagine Quant Group. So they are focused on building large databases of brain tumors with detailed segmentations and clinical information. So they would like to provide high quality annotated data. They work on developing informatic tools for improvement of the patient care, but also they work on some preclinical research and clinical trials. So at the beginning, I would like to thank to people and groups that made all of this possible. So most of the time, during those 3 months, I was anchored in Imagine Quant Lab and Brad Smith's community, but I also learned a lot in AI Research Core lab at CHOP, where the PI is Dr. Susan Sotardi. And of course, I am grateful to our mentor, Dr. Aboyan, but also for the guidance from Dr. Lin, who had more engineering-based insights, and he shared his point of view from imaging from commercial point of view. And I would like to thank Sano for supporting me during my stay at CHOP, and warm thank to my colleagues from the lab, Fabian, Nazanin, and Raisa, for their openness and fruitful collaboration. And I will share what were the fruits of this collaboration. My internship objectives were daily to observe neuroradiology workflow, but from the radiologist perspective. So during these rotations with Dr. Aboyan, I could identify where current AI tools actually fail in practice, which ones worked, and where are the gaps for realistic, clinically useful AI. So doctors could report what needs they actually see, so we could confront it with our ideas. And I wanted to contribute to ongoing translational AI projects at CHOP and possibly build a foundation for future research direction in clinically integrated AI. A summary of the outcomes is as follows. We submitted two abstracts to RSNA. One got accepted. Then we extended our work and submitted an abstract to CMKIMI conference. It was accepted and also presented. The manuscript on research packs prototype is in preparation, so it soon will be out. But some results of it were already presented with Dr. Aboyan at ASNR conference workshop on AI deployment. We are also preparing the manuscript on inter and intra-rater variability in brain tumor segmentation. And additionally, while attending ASNR conference in Philadelphia this year, I moderated one session and presented an abstract on image-based search in radiology. So I will move now to our RSNA abstract that I had the opportunity to present recently at RSNA in Chicago. And it was on staple-based reliability analysis of multi-annotator brain metastasis segmentation data using Brad Smith's Lighthouse 2025 challenge. So when we build AI models, we often think about ground truth as if it was absolute. But as you can see, in reality, it's rather range of interpretations than one single truth. Volumetric segmentation of lesions in the brain is critical for surgical planning and treatment tracking, but the tools that we have for volumetric segmentation remain poorly standardized, and also taking into account how common are metastasis incidences in oncology patients. We really need reliable segmentation tool to enable lesion tracking. The challenge we observe is inter-rater variability in manual annotations. That another challenge is that AI require high quality annotated data for the training, and the performance of these AIs will have critical impact on treatment response assessment. So key highlight within those challenges is that there is no defined clinically acceptable variability and reference standard for brain metastasis segmentation. And current models are pushed to perfectly match a given mask from a single annotator and kind of imaginary 100% dice score. So the goals of this abstract were as follows. We wanted to quantify expert variability in brain metastasis segmentation, generate staple-based probabilistic reference standard, and benchmark manual versus NNU-net assisted segmentations against this reference to characterize realistic performance ranges. We used the multi-annotated data set of brain metastases that was described within a 2025 Lighthouse Challenge. Here you can see the study design. So we had 75 cases, 3 cohorts. Each case was segmented effectively 8 times. We had 3 rater pairs 6 board-certified neuroradiologists, and half of the segmentations were adjusted pre-segmented masks, and half of them were segmented manually from scratch. Having all those annotations, we created Staple Fusion. Staple is a well-established algorithm that has like 20 years, but it still can work as state-of-the-art. It creates probabilistic estimation of the ground truth, taking the fusion out of multiple annotations. And it iteratively adjusts this reference mask because the annotators that were better have higher weights, and that's why our reference mask gets improved iteratively. At the end, we calculate our metrics, dissimilarity coefficient, Fleiss kappa, Krippendorff's alpha, and sensitivity and specificity. Here you can see the representative case of variability on the flare sequence, and it's a direct representation, so red color, green color represents full agreement, so 8 annotators agreed on those voxels, and then medium agreement represented by yellow color, and low agreement were less than 4 or less annotators agreed, and the blue mask denotes our consensus estimation. We calculated intra-rater dice score, and we obtained the value of 0.82. Inter-rater dice score was 0.79, and mean dice score versus staple reference mask compared in live-on-out approach gave us 0.81, and metrics like Fleiss kappa and Krippendorff's alpha were both of 0.2. And what does it mean they were 0.2? So these metrics are interpreted in the way that O is random agreement and 1 is perfect agreement. So at least for me, it's a bit surprising because 0.2 we would interpret as only fair agreement. So it's not so great agreement as you would maybe expect, as some people would expect. We compared the consistency, performance, and dice scores, taking into account whether the segmentations were done from scratch or there was pre-segmentation, and NNU assisted segmentations had plus 18% dice score improvement. AI assisted was also better than paired consensus, and paired consensus was better than manual. And like one sentence to sum up those comparison between manual and AI assisted segmentation, we can see that AI segmentation gives us more consistency. And I think what is also important to add is that segmentations were done while being screen recorded. So this is an important feature when we talk about high quality data. So it may be important part when talking about bias, for example, in segmenting. So yeah, summing up, AI pre-segmentations gives us more consistency. Apart from doing inter and intra-rater variability analysis using staple in live-on-out manner, we compared to simply simple majority vote mask. So it means left out rater versus majority vote mask of remaining raters. It was assessed this way. Here we extended our analysis beyond metastasis. We calculated the dice score for glioma and meningiomas, and we can see the meningiomas obtain in general the highest scores, and met and glioma land lower, and especially for the necrotic core. Here I presented the illustration of how we fuse multiple annotations, and you can see these are synthetic segmentations, but you can see how disagreeing areas are being smoothed out, and we can binarize it to obtain our consensus. We can also show uncertainty, or we can show the variability in the form of entropy. In this second abstract that we sent to RSNA, we wanted to use conventional metrics like die-score, linear measurement, Hausdorff distance, and average symmetric surface distance. And again, we calculate. Here you can see that in metastasis, we observe the widest range in distance metrics. Summing up this section, manual expert segmentation in metastasis shows reliability of mean die-score 0.81 and kappa 0.2, and NNUNet assisted workflows significantly outperform manual segmentations. Staple algorithm can give us spatial uncertainty of annotations and offers probabilistic reference standards. The baseline consensus yielded a mean leave one out linear measurement difference of 5 millimeters, and this approach can inform annotation protocols, quality assurance, and AI models that will account for variability. Going back for a minute to our second abstract sent to RSNA, we used those 4 conventional metrics to create composite score, where we could do iterative improvement of our consensus mask, like being inspired by Staple. And all metrics had the same weight in this approach. But we had from the beginning the intuition that probably it's not that simple. They probably should not have the same weight. So we submitted another abstract with introducing disagreement profile when calculating inter and intra-rater variability. So we proposed composite score to weight not only annotators' contributions, but also the contributions of individual metrics. Why do we want to go beyond Staple, even though I said it's a very good and well-established algorithm? So in clinics, often, like, current routine is that doctor will draw a diameter to track the size of the lesion. So we wanted to use conventional metrics that will probably be more user-friendly, and we would like to introduce interpretability in our consensus estimation. So we want to propose disagreement profile to guide metric-aware, fairer consensus rather than relying on a single fusion step or just a staple mask. And the innovation in this step is that we convert metrics to percentile ranks using cohort-specific Z-scores and normal cumulative distribution function for direct comparability. Again, what our metrics mean here. Average symmetric surface distance shows us boundary placements disagreement, average of it. Hausdorff distance shows the extreme boundary disagreement, so it calculates the worst, the highest distance. We have linear measurement difference, and annotated volume similarity is expressed by die-score. Each metric is normalized, turned into percentile score. So it means, putting it simply, that at the end we have the answer to a question: what fraction of annotations in the cohort are worse or better than this value? So algorithm selectively will amplify annotator strengths based on their metric-specific performance and the case metric weighting. And this is the result. So this is the transparency that we wanted to show. On the radar plots, you can investigate more closely why an outlier case was an outlier. So on the left side, you can see the high agreement case. The yellow lines, the yellow line denotes the Z-score. So if the values of the metrics are inside of it, it means that we have overall good agreement. But if it exceeds and we observe outliers, you can track which metric specifically cost exceeding the average, and it can suggest that maybe this specific case need to have additional review or specialized expertise may be needed. We compared results from this profile guided consensus, and we obtained higher dice score compared to staple and lower distance metrics. So all this narration circles around how do we approach peak ground truth. In 2025, we have this multi-annotated high-quality data set. So we are actually able to calculate inter and intra-rater variability. But even earlier, researchers knew that probably forcing AI models to obtain 100% dice score is not a good approach, because probably there is a point that is called peak ground truth, and when you go above this point, it likely means that you are kind of overfitting to the noise or trying to match too much to a single mask. So peak ground truth will lay between inter-rater and intra-rater variability. And this is what we actually calculated per each tumor, intracranial tumor, and each label. So these results will be presented in our upcoming manuscript. And I think it will promote thinking of shifting paradigm in training of AI models, because now researchers will be able to refer to the variabilities and have better idea how they should optimize the AI algorithms, because we now clearly see that the optimization to 100% dice score is not the way we should go. Now I will go to more translation part and why it's hard in radiology AI. So this part is about a prototype for integrated clinical and research packs for real-time image and text annotation in neuro-oncology. There are several challenges with deploying AI in clinics. So hospitals run on their classic legacy systems with limited IT capacity, and AI models come as requiring modern infrastructure. They are usually cloud-based, and this is hard to integrate. AI models must be monitored for bias and safety. Often, hospitals are buying point solutions, so this leads to unsustainable AI support costs. And another very cumbersome part is that fragmented electronic health records systems make it hard to integrate AI, track outcomes, and basically manage everything when we have fragmented EHRs. And as I mentioned before, the Imagine Quant Research Group is focused on creating large databases of high quality annotated data. And specifically, when we have fragmented systems and a lot of manual work, creating those databases is very laborious task, because if you don't have AI embedded in your PACS. You have to download the DICOM, then give it to a neuroradiologist that will upload it to the segmentation software, perform the segmentation, and then we will export segmentations via Nifty files. And researchers have to manage spreadsheets and forms. So it's fragmented and not optimized. But when we compare to this idea of having the tool inside of the PACS, there is one smooth step, just using the tool and performing the segmentation, and everything stays in one place. So we propose to divide the clinical PACS, and PACS is picture archiving and communication system that is part of radiology information system in the hospital, and then the higher instance is hospital information system. So PACS is for archiving and sending images that were acquired during the study. So we propose to divide instances, to split into 3 instances where we have clinical PACS for patients, advanced clinical measurement PACS, and research PACS. The clinical PACS would be the PACS that is a current system that we know, where radiologists pull up the studies, report them, and then they export a diagnosis, which is a legal document, and they have all the data about the patients. Advanced clinical measurement PACS is also called clinical trial PACS. So there you can perform the measurements that were agreed in the clinical trial protocol. So you can do experimental measurements that wouldn't be allowed in a classic clinical routine. And research PACS is basically like a sandbox where you can keep your databases. The patient data is safe and de-identified. We can access this data at any time. We can add any edits, and it has the least regulatory clearance. And now I will stick to this framing of regulatory clearance, because this is very important. I think differentiating those instances. So we can see 2 types of users. We have radiologists and researchers, and they have different needs at different stages. And when we look on the right side, at the bottom, we have research PACS instance that is not subject to FDA clearance. It only requires IRB approved research. So internal review board gives us green light to use our AI tool, and we can use it on de-identified patient data. Clinical trial PACS, a level above, must follow clinical trial protocols, but we are free to use our novel tools. And the clinical PACS can only use if any AI is used there, it must be FDA cleared. So any new AI tool that was not cleared simply cannot be used and showed to the patient, because we don't want any measurements that are outside of routine assessment. Here's the example, like the proof showing why do we need the lesion tracking tool and why it's important to have it inside PACS, because usually the radiologist will look at the prior study, and on this example you can see the difference is not that prominent, but when you look back to a couple of previous data points, you can see the trend. and that helps assess treatment response, treatment planning. And that's why it's handy to have the lesion tracking tool inside the packs available for clinicians. This slide is supposed to resemble the situation when you are approaching to buy some hardware in online store and you compare the features. So we can see which things the research packs has, and for example, clinical packs doesn't have compared to research packs. And we take the MRI data from hybrid clinical MRI and research protocol AI algorithm study, and we compare. So in clinical packs, for example, we don't have this longitudinal analysis lesion tracking tool available, but in clinical trials and in research packs, we will have it. What is very not handy for research is that in clinical packs, you have only the real time read, and the report cannot be changed after that. We cannot do any additional analysis, but we are able to do it in our clinical trial packs or research packs. What is very important in research packs, we have anonymized data. Another important part is that on clinical packs, there are only FDA cleared tools for routine use. If not cleared, AI must carry a disclaimer and not be used for primary decisions. Data from clinical packs is available in EMR, and data from other two instances stays in these instances. What is also interesting that in our research packs, we can leverage segmentation AI tools and extract radiomic features. And all of those lessons and experience that I had with inter and intra-rater variability measurement and segmentation algorithms, and also connecting to my interest into explainability and interpretability of the models, it led me to submitting a grant project that will start January next month. So we proposed to develop an AI algorithm for longitudinal tracking of post-treatment changes in brain metastases using hybrid uncertainty-aware explainable architecture, accounting for inter and inter-rater variability in segmentation. So I will sum up the gaps that we are trying to address here. Now, routine clinical assessment of lesions relies on simple 2D measurements, even though it was shown that volumetric tracking is more reliable. Small brain metastases are difficult to segment and follow over time. And when AI remains a black box, we have lower clinical trust, so slow real-world deployment. We discussed quite a lot about uncertainty, but a part of it we have explainability, and Salvi in the work they published said that the explainability and uncertainty are the two sides of the same coin. And also we can read that uncertainty can be used to identify confidence of generated explanations, and explainability can be used to explain the source of the model uncertainty. So we would like to move towards calculating the aleatoric uncertainty, which means data-driven uncertainty, and also epistemic uncertainty, which means model-driven uncertainty. And we can combine it with explainability, because our explainability outputs, they can be uncertain as well. So we can report many things a part of prediction of the model, and these things should contribute to better adoption of our AI tools. And our third hypothesis is that we will test whether uncertainty dynamics can serve as a biomarker of tumor heterogeneity and/or heterogeneous treatment response. So now we have some studies that were testing the integration of volumetric lesion tracking tool into the PACS, but in our iteration of studies, we would like to add this uncertainty-aware volumetric segmentations to support neuroradiologists in treatment decisions and improve safety, transparency, and efficacy. And small thing, I called it spin-off related to our project on uncertainty-aware explainability in brain tumor segmentation, is that we'll be working on a toolkit for uncertainty quantification for brain tumor MRI datasets. It's a project for master's thesis or other student project line. The goal is to build reusable toolkit that we can plug into existing MRI analysis pipelines and report safety first metrics. And another interesting angle of this spin-off is that we can work on creating engineered uncertainty quantification benchmarks. So we can add controlled perturbations to test whether model uncertainty and abstention will truly increase with the data difficulty. So key messages from my today's talk, maybe as advice to the researchers, to myself, we should start with workflow mapping, not with the model. Output should be more than a predicted label. We should report calibrated probabilities and uncertainty with explainability and/or interpretability where possible. Having our data from Brad's Metz Lighthouse Challenge, we can design around human variability a window, not an arbitrary dice score of 1. And expert disagreement is a feature of reality, not a noise to be ignored or fixed away, because our study was based on board-certified neuroradiologist segmentations, so we consider it as high quality, and still we have the visible disagreement. Stable algorithm and profile-guided consensus improve reference standards for segmentation. When there's AI assistance in segmentation, we have increased consistency of annotations. Successful translation requires infrastructure. For example, the 3-instance PACS. And the next step that we'll be working on is uncertainty-aware explainability, longitudinal tracking, calibrated to human variability to ultimately improve patient care and treatment planning. And with that, I would like to thank you so much for listening and happy to take questions.
Monika, many thanks for your talk. Well, we will wait for questions from the audience. We have already Olaf with his question. Olaf, please go on.
Thank you very much for the interesting talk. I can't talk too loud. We have a second video conference in the room here. I hope you can hear me well. I have first a technical questions. In your Fleiss kappa, the intra-annotation was even lower than the inter-annotation. Do you have any explanation for that?
Probably that was a typo if it happened that way.
Was slide 15, so I wondered whether there are certain, let's say, categories of images that have more disagreement than other categories of images or lesions, that may lead to that very strange result?
Okay, so I focused on reporting our means, flies, kappa, and creependors, and I have to admit that that was the work led by my colleague. And I think you're referring to this table.
And you see the inter-annotation is better than the intra-annotation. That is...
Yes, that is puzzling. I don't have, sorry, I don't have your answer to that.
It is a point to discussion with authors of
okay.
Yes, we will discuss with colleagues.
Okay, good. I have 3 other questions actually. So the one thing is you were talking about this triple PEX thing. I was wondering, is there any chance that the research and the clinical, the advanced clinical will get in existence without anybody paying for the clinical? So you, of course, it's easier because you don't need these, let's say, high rate of regulatory approval for the other two. But on the other hand, the clinical PECs would pay for all those other 2 instances because they would not be financeable on its own. Yeah, and also the data that they are collected in the database, that is something that, well, if it is expensive, this will not be reimbursed just by some research grants. So on the overall, you need a clinical PECs in order to get enough data, get enough patient data into that are necessary for the research PECs and the advanced clinical measurement PECs. So the question is how, so that means you need to have the clinical PECs in principle first, don't you?
Yes, clinical PECs is essential, and I don't think any hospital can function without it.
But
I don't know if I got the question.
Well, the problem is the clinical PECs is difficult to get with AI. Yeah. Well, you referred to the FDA system now. Since more than a half a year, you are back in Europe, and here you will know that the AI Act and the MDR regulations are not easier than getting certified by the FDA, but rather more difficult. So that the question is, do we have a chance to get a clinical PECs with AI at all? So because if we don't, then the other things are theoretical concepts because they will never get into existence without a clinical PECs with AI.
I mean, I would say the prototype is a theoretical concept itself, even though I know that researchers that initialized it, they worked, they get at the further point at Yale University. So when they moved to Children's Hospital of Philadelphia, they had another tweaks and ideas. So we put it into description as a current project of 3 instance packs. And another idea, if it won't be possible because of legal regulation, is that maybe we could do a complete analysis, like bypassing packs. So now you can observe there's a problem with AI models outputs that vendors and startups offer, that you can have a prediction, but it's written in a report in PDF, for example. So when the doctor would like to edit anything, it's not possible. So I don't know. I hope this will be possible legally to have these 3 instances, but it's not the only idea, because we have other theories. I don't know if this answers the question.
Well, partially, yeah. So last question, you're back in Poland right now, and the question is, there is a large database in Philadelphia. Do you have access to that after that? Is there still an ongoing collaboration that allows you to use that very valuable data?
I don't work specifically on that project, we have access to Brad's data, the types of tumors that I listed. But if the time allows, probably I would be able to access this data if we agree that I will be contributing to the research.
Okay, thank you very much.
Thank you.
Thank you, Olaf. Maćku, well, go on, please.
Okay. Yeah, so first question is also about this data, because in our Gaia AI Factory project proposal, we have some activities regarding these BRATS data sets. So can you tell us a bit about these planned activities?
Planned activities at Gaia. It can be related to, I think, our accepted grant. So we have access to Brad's data of different tumors, and the multi-annotator data was not open source because of the challenge. But as we get manuscripts out, I think the availability of the data will be there as well. And for the Gaia project, we can definitely contribute developing improved segmentations and our uncertainty measurements, uncertainty benchmark, and explainable AIs. So summing up, yes, we will have the access to the data, hopefully, and we are on the track to start the proposed research according to the plan.
Yes, thank you. So this, I think the seminar was a nice introduction to these topics, and also, just a comment that I think this uncertainty quantification is in these AI models. This is something which is getting more important, and this is, of course, a bit different type of uncertainty quantification that we do in the case of simulation-based models. But maybe kind of follow-up question would be, could you tell us also more about this, some future plans about this uncertainty quantifications, and also how it relates, to these uncertainties that are present within human experts and so on. So something more about future work, let's say.
So I agree that definitely after having decent AI models, researchers move towards taking care of adding also the probability, uncertainty, so the user can see how much the model can be trusted. And having this BRATS-METS multi-annotated set, what is interesting, what we can add above of calculating probability, uncertainty, and calibration, classical calibration, and having the explainability, is that we can calibrate to this human variability. So before, we only had hints that probably we should not exceed the peak ground truth, and that we should be careful about choosing our metrics, because it matters a lot. How do we optimize our model? Because if it optimized on not well fitted metric, probably the real world performance of it won't be as good as it could be. And I would say that another pretty novel thing that is pretty recent, because the publications are from this year, is to look at uncertainty as a output that is to look at explainability as the output that also has uncertainty, and these two features are complementary. So as here researchers proposed on these two pieces of jigsaw, that they provide information about each other, and we would like to leverage it and add some biological context, because we have this hypothesis that maybe the uncertainty can be kind of biomarker in the tumor heterogeneity assessment.
Mm-hmm. Yes, okay. Thank you very much.
Thank you.
Well, many thanks, Maćku. Now we have in the queue, we have Wiesław Nowinski. Wiesław, could you please go on?
Yeah, thank you. So congrats for your RSNA and ASNR abstract presentation. Did you attend the meetings in person?
Yes, I attended the meetings in person in Philadelphia and Chicago.
Okay. How did you like them? What did you learn? Because these are huge meetings. So can you recommend these meetings to your colleagues?
Yes, definitely. Definitely. And ASNR and RSNA are different because the RSNA is, I think, the largest conference in this radiology field. So you can meet there everyone and a lot of vendors. So if you are interested in talking to vendors, selling hardware, software, doing R&D, they are there. ASNR is also a very nice conference, and the advantage of it is the opposite, but it's still the advantage. It's more small community, so very open people. And at ASNR, I had the chance to moderate the session, so to train this skill. And I would say the RSNA is a bit more fitted with my scientific interests. So you can definitely observe and confirm which are the trends and what are the important things that you should focus on. So I heard many times about uncertainty, and people were repeating after Fagani's work, for example, that not only prediction label, but probability uncertainty. So yeah, you can observe new trends and also make sure that you're going in the right direction. And I would definitely recommend attending.
Wonderful. I have the same opinion. How many people attended this year, and how many companies? Do you have any numbers? Because at least before the pandemic, when I attended, it was up to 50,000 people, up to 700-800 companies. What's the situation now?
I didn't check the numbers, but it was, I can tell that it was overwhelmingly huge. And really, I met the friends that I was only meeting online, because like literally everyone is there. So two huge areas are reserved for vendors. Sorry, I don't have the numbers, but I am sure it was huge.
Okay, so coming back to your presentation, you were talking about expert disagreement. Did you take into account years of experience?
I don't know the exact years of experience, but the feature that we put there to make sure that we have the highest possible quality is that the specialists are board certified. So these people are definitely not trainees, and when the trainees were segmenting, they were supervised by board certified neuroradiologists. And as I mentioned also quickly, not even they were top specialists in their specialization, but also segmentation process was screen recorded. So we can make sure that they were fully focused on segmenting, regardless of having the pre-segmentation on, or doing it from scratch.
Yeah, because I believe in several journals required to give the number of years of experience. Anyway, about 30 years ago, I did a little bit similar project, meaning trying to estimate the accuracy of manual segmentation by clinicians, but I did the experiment that, let's say, original slices are axial, you show some axial slices, and I had the same case for the same person, but in coronal or sagittal. And difference between orientations were up to 30%. Did you try this kind of experiment with your raters?
We calculated it volumetrically. So we didn't check like how it differs when you look on the sliced and regardless to the axis, but it sounds very interesting.
Yeah, I was really surprised that the same person, the same tumor was evaluated so differently. Yeah, regarding PEG system, so I also face this kind of problem in the future. I think it's a great idea, this triple instances, but if you want to implement, you need to have the PEGs opened by the vendor. Did you talk to the vendors, or is it necessary to open it for any extensions?
So the prototype that happened at Yale University was in collaboration with the vendor, and the vendor was taking care of, for example, specific web forms when you can edit mineable enriched data, and the vendor was taking care of implementing the lesion tracking tool, working with the researchers. So yes, I think this factor is important, that you have some collaboration established with the vendor.
Yeah, working on the brain tumor database, it's really great. As far as I know, there is no such a database in Poland. Do you think that your work can contribute to really developing such a database for clinicians?
We can definitely try to apply similar solution in the hospitals. But another thing is that we would need to have interested clinicians to do these segmentations. And I think the difficult part is talking to the vendor interested to the hospital. So definitely the prototype of 3 instances is a good idea. It leverages the deployment, and why not? It seems like a hard task to do it from scratch in Poland, but we have the ideas already, and why not using them, I think.
Okay, so thank you and good luck.
Thank you so much.
Many thanks, Wiesław, for discussion. Well, I have just a small question. Could you please explain more about these AI methods which were used here?
The pre-segmentations?
Yes, how it worked, and it was something what you have developed, or it was built of some available modules and.
NNUNet. It was it's an abbreviation for no new UNet, and it's I would say still state of the art segmentation model for MRI tumor segmentation. It has very specific. It automatically adjusts the preprocessing of the data, and that's why the segmentations are considered decent. So the model was not specifically designed and developed for this study. The pre-segmentations were from NNUnet that was described and was already out there.
I think that probably in it would be more detailed description. Probably it will be useful, because the question is what basic features and how they are used in combining this together with what experts say. But anyhow, thank you. Well, do we have more questions? Well, I don't see more questions, so I would like to thank you very much. Well, it is thank you very much, not only for talk, but also for, let's say, this very efficient and effective usage of your time spent with Marianne in Philadelphia. So many thanks.
Thank
And well, all the best in your future work in this direction. Thank you very much, and many thanks to all participants of this seminar. It was the last seminar before Christmas and last in this year. We will resume our meetings in January. And in January, we will first we will come back to our, let's say, Nobel series, and this time it will be a kind of talk on, you know, maybe you will be somehow surprised that it will be about Nobel Prize in economic sciences. However, but it will be about how new technology can drive sustainable growth. So I think that what we are working in Sano is research on new technologies. So I think that this type of seminar will be very useful for us. And then we will go to seminar of our PhD student Rosemary Blanco. So this is the plan, and we will meet on 12th of January 2026. So all the best for Christmas and for New Year. And of course, we will send announcement of the seminars, so you will have all information which will be required to join us. Bye.
Thank you. Bye.
Thank you. Bye.